Lá pra cima. Olá, Ike.
Então, qualquer coisa que faça aí, anatomia distorcida que tem risco.
Bem.
Acho que é uma intolerância, anestesia geral. Eu entendo.
We'll do this one first, on the forceps. This is first, then we have the lidocaine. Lidocaine. Sure. And we have enough BSS. I mean, you're getting wrong BSS, so we have enough for 3cc is better than that.
Vamos abrir tudo, se liga de 3 ml, botar BSS.
Okay, first Q add-on in the house. Medicontur.
Medicontur, please.
Yes, baby. Does this microphone have an earpiece too? Listen or no? How can I hear them? So this is the microphone. Okay, sure. It's Bon Jovi.
Ike, can you hear us?
Hello. Hola. Boa tarde.
How are you, my friend?
I'm great. Can we turn the volume up? Okay. Sure. Just a sec.
Just a second, we are not hearing you.
Oh, can you hear me now?
Now it's fine, perfect.
Okay, thank you. Nice to see you. I hope you can see the cameras okay here.
Yeah, it is. It's perfect.
This is a patient of ours that we are performing an AddOn Sulcus lens. It's a trifocal lens. This patient's had cataract surgery in the past, pseudophakic. This eye actually has a T5, so this is a toric lens in the eye. And she's fairly happy with her distance vision, but she desires to have improved near intermediate vision. We've actually done her first eye, her left eye, yesterday. And I talked to her this morning, and she is very happy. She can actually read and see her phone and read books with her left eye already. So it's been one day with the AddOn lens, and she is very happy. So she's very pleased about getting this eye done as well. The idea of a sulcus-based AddOn lens is a very intriguing idea as a secondary option for patients who already are pseudophakic. And the idea is fairly straightforward. Place a biocompatible, anatomical compatible lens in the sulcus to allow for improvement of range of vision. Is this lidocaine? Lidocaine. Put some lidocaine in here as well. And I want you to think about the possibilities as well of even considering primary implantation in eyes perhaps where we may have a concern, perhaps eyes where we have a high degree of cylinder. These AddOn lenses can do a lot in terms of the ability to allow for reversibility as well. We are just actually going to be loading the lens. This happens pretty fast. So let's take a camera view of that. I'm making an incision here. Minimum incision is 2.4 millimeters that can be used. So you can choose what you're comfortable with. And this will basically allow for the placement in the eye. Now let's get a view of the AddOn lens. It's a very unique lens. Most lenses are 1 millimeter in thickness. This is 200 microns, 0.2. 20% the thickness of a regular IOL. It's vaulted anteriorly to keep it away from the existing lens to reduce the risk of intraocular opacification. Now there are many different types on the market. This is the first Q AddOn lens from Medicontur. And this has a unique design. I don't know if we can see a picture on the camera, but just to show it, it's got a 4-point fixation. It is not the typical C-loop, and because of this, the rotational stability is optimized. The material is an interesting copolymer of hydrophobic and hydrophilic design, 25% water, and the edges of the optic are round-edged. And this allows, again, to reduce the risk of chafing of the iris. We always worry about this, of course. And so this lens is really designed optimally for the sulcus placement. I typically use a cohesive viscoelastic agent to create space in the sulcus, lifting up the iris, and this allows for the placement of the lens in there. Probably the most challenging part of the surgery is folding the lens, which isn't really challenging, but not to put pressure on our staff. But it basically tucks into the bridge of the the cartridge and then placed through a single-handed injector system. I'm going to use viscoelastic in my other hand to allow me to guide the haptics in here as well. So there's the lens here.
Pode voltar para o microscópio.
Are you guys okay?
Yeah, you're fine.
Okay,
Just
thank you.
change that to the microscope again. Thank you.
We're going to find the lens here in the cartridge. It will go bevel down. And it's a very controlled delivery. This basically allows for, what size incision was that, lady? Can you just check on that?
175.
Can I see that for a second? I'm just going to enlarge the incision just slightly, just to allow for me to place the cartridge into the anterior chamber. I want to do this without much struggle. Just slightly here. There we go. Now this can be done probably wound assisted, but I'm going to use an intracameral delivery just to make sure I have control of the lens into the eye. There we go. Okay, let's proceed now. I'm going to start here fairly planar. Aim posteriorly a little bit. There the haptics unfolding. Nice little rotation. You guys can see okay?
Yeah.
Great. I'm going to try to tuck the leading haptics underneath the iris. And I want to avoid too much posterior displacement of the lens. Controlling delivery here. There we go. Do we have a hook I can use?
Yeah.
So we have 3 haptics done. I try to get 4 in, but sometimes you got to do another maneuver here. We have minus tab too. Can you use that?
Temos cavacal para ele usa 1.1 para 1.
So there we go. There's the lens. Now this comes in a toric platform, soon to Brazil. You can rotate it if we need to. And you can see this lens is positioned quite well centration-wise. Now, that's the surgery basically. It's fairly efficient. For viscoelastic removal, we can use automated IA. I'm just going to manually express the viscoelastic. It's cohesive. Use that.
Do you take some special care about the interfaces between the IOLs?
I don't typically do too much there. This will basically hydrate and clear. Very much like ICLs, With ICLs, I don't like to go and do too much work under the lens. So basically, over time, it hydrates up. The volt may be a little bit more on the first day. That's okay. And thank you. And so basically, that's the surgery essentially. We're going to hydrate the incision. This is carbachol. You can see that the lens is well positioned. Let's ask her to. Hola, Lucio.
Olha a luz.
Olha para luz. Hola para luz. Okay, great. You can see the centration. Look at it. It's right bang on. That's the coaxial light reflex. Looks quite good. I'm happy with that. So, that's basically the procedure. So think about the possibilities of patients perhaps who have residual cylinder, patients who perhaps will desire some enhanced range of vision. This lens comes in an eat-off design as well. Notice that there are only 6 rings, because this lens is an interesting design. It's a combination of diffractive and refractive technologies. So think about it again. So it's got the benefit of having the diffractive design of basically splitting light, along with the refractive design to provide more continuous range of vision. They call it EPS, and it's a clever way that they can enhance the continuous range of vision, intermediate as well as near.
And share with us, why don't you go with the IA and you prefer to
Ike,
irrigate the AC with
were you injecting OVD during the injection of the IOL with your left hand?
No, I didn't do that, but I have it ready if I need it. That's why I kind of like the OVD in my other hand. Just in case I need it, I can inject some. I didn't have to do it from this. Now, I should mention that we could have gone with the IA automated to remove the viscoelastic. I didn't choose to do this here. And the reason is because sometimes in these patients, especially if they're many years post-op, there might be some zonular issues, there might be some risk of vitreous coming forward. So I prefer to do a controlled maneuver, just irrigating the OVD out. I will put the patient on some acetazolamide, a couple of doses. We did this yesterday as well. And this prevents a post-op IOP spike, but I'd rather deal with that than deal with any vitreous. And sometimes if you do enough of these cases post-op, you'll see sometimes vitreous can sneak around the zonules, even in routine post-op pseudophakic patients. So that's my rationale for not using automated IA. Okay, well, I mean, that was a pretty boring case, but I guess that's what we want to see when it's boring, right? We want things to be boring and controlled. I'm very excited about its potential. I mean, I have to obviously be worried about concerns around sulcus irritation, but this lens has shown a very good history. I think by its very thin design, round optics, 4-point fixation, it seems very biocompatible, very safe to use in these eyes. I would be careful maybe in an eye that had a very small sulcus. Maybe in a nanophthalmic eye, we should be careful using this case. But in most eyes, with the sulcus being relatively normal size, I think it's a very good option. And patients who desire something after pseudophakia, or even primarily, maybe somebody who you're worried about maybe long-term having a problem, you put a monofocal in the bag, trifocal in the sulcus, you can take it out if you don't like it, right? Or eat off, you can exchange it, fairly straightforward. So think about what you could possibly do in terms of the options of using multiple IOLs at the time of surgery as well. Well, that's all we have for this case. I have another case later on, so stay tuned. Phaco Brazil.
Ike, thank you very much. We'll talk soon for your surgery. Agora a gente vai dar sequência.